Dear students, in the last class we are discussing pleural effusion, its clinical features, signs, and complications. Today we can move on to the investigations, TD, and management of pleural effusion. First of all, the most easy and accessible investigation is chest X-ray itself. Chest X-ray. We can diagnose pleural effusion very easily in chest X-ray. And about the points you get in radiography or in chest X-ray. First of all, there is obliteration of costophrenic sinus on the affected side. Usually the fluid is filling from the costophrenic recess and it gradually rises up, and the fluid is quantity of fluid is very large, can come up to the clavicle level itself. So the first change you get is obliteration of costophrenic sinus on the affected side, and the opacity extends up the chest wall and is concave towards the lung in PA film. Usually we will suggest post-trantor view or PA view for detecting lung pathology. So in case of pleural effusion, you will get opacity, and the opacity is uniform opacity, and depending upon the level of fluid, the opacity gradually increase. And the important point is the upper part of the opacity is concave towards the lung, or it is curved in the film. So the highest portion you get in the axillary area or in the sternal area. So there is a curve like upper portion that is typically seen in pleural effusion. So it's very easy to detect pleural effusion in chest X-ray. And if the effusion is very small, or there is only a lesser amount of fluid in the pleural cavity, and if we are unable to detect in the erect posture, ask the patient to recline. Or we can take the X-ray in the lateral decubitus view, or the lying down sideways pose, that is lateral decubitus position. So the first and important investigation we can suggest is X-ray itself, that is opacity, or you'll get uniform opacity in X-ray. Then we can suggest ultrasound also, can confirm the presence of pleural fluid. Then CT scan is very helpful, can demonstrate the quantity of fluid or the level of fluid, pleural pathology also to some extent. Then examination of pleural fluid is an important measure. Examination of pleural fluid. In that, we can do cytology, biochemistry, bacteriology, and immunology. All this can be done with pleural fluid. In case of cytology, we can note the type of cells. In case of X-ray and all, we will get a variety of cells which give, if you can detect a particular type of cell, and then it is easy for treatment also. So if the Mycobacterium tuberculosis bacilli is detected, or you can directly move on to antituberculous treatment. So cytology is important. Then biochemistry. In biochemistry, presence of proteins and its specific gravity and presence of protein is also, detection is also very important. Then LDH, presence of LDH in biochemistry, that is, it is elevated in tuberculous effusion. Then glucose, presence of glucose, it is below 30 milligram per 100 ml in rheumatoid effusion. It is less than 30 milligram per 100 ml in rheumatoid effusion. Then in case of pancreatitis, serum amylase will be high. Serum amylase will be high. Serum, not serum amylase, the amylase in pleural fluid. Then fat content. Fat content is high in chylous effusion. Fat content, presence of fat content. Then bacteriology of this pleural fluid. We can do culture. We can do culture to detect pathogenic bacteria. Then examination of fungus, etc. Then immunology. By resorting immunology, we can do RA factor. RA factor in case of rheumatoid effusion. Then antinuclear antibody in case of other connective tissue disorders like systemic lupus erythematosus, etc. So all this come under biochemistry. That is this protein, estimation of protein, then LDH, glucose, amylase, fat, all this come under biochemistry. Then bacteriology is there, immunology is there. All these come under examination of fluid. So cytology, biochemistry, bacteriology, and immunology. Then another investigative procedure is bronchoscopy. Bronchoscopy is advised when we suspect some malignancy or there is presence of some foreign body. Then isotope scans are there. Two type of scans are there: ventilation scans and perfusion scans are there. And it helps to detect pulmonary embolism. This ventilation scan. Then thoracoscopy or fibroscopic fluoroscopy is there. It is helpful in recognition of early case of malignancy and TB. That is thoracoscopy and fibroscopic fluoroscopy. Then another investigation is pleural biopsy. It helps to find out this malignancy and or pleural biopsy. Malignancy, there is pleural malignancy, pleural mesothelioma, etc. We can take pleural fluid also, or pleural biopsy using a needle called Abraham's pleural biopsy needle. Abraham's, you might have heard in surgery. Abraham's. This Abraham's pleural biopsy needle. Abraham's pleural biopsy needle. So that's about the investigation. So different investigations are employed in diagnosis of pleural fluid. That is X-ray, ultrasound, CT scan, examination of pleural fluid, bronchoscopy, isotopic scans, then thoracoscopy or fiber optic fluoroscopy, then pleural biopsy, etc. Then we can move on to the differential diagnosis also. We can divide differential diagnosis under two headings, that is conditions above diaphragm and conditions below diaphragm. The conditions above diaphragm include thickened pleura, empyema, hydrothorax, lobar pneumonia, fibrosis of lung, massive lung collapse, bronchial carcinoma, then large pericardial effusion, then pleural mesothelioma, cardiac enlargement, hydatid cyst. All these are conditions coming above the diaphragm. That is, so the lead is coming above the diaphragm. That is thickened pleura, emphysema, empyema, then hydrothorax, lobar pneumonia, fibrosis, massive collapse of lung, bronchial carcinoma, large pericardial effusion, pleural mesothelioma, hydatid cyst, cardiac enlargement, etc. So these are the conditions above the diaphragm. Then there are two conditions coming as DD under or below the diaphragm, that is subphrenic abscess and liver abscess. Subphrenic abscess and liver abscess. We will just refer the points for differential diagnosis and prepare notes. So these are the DDs, that is conditions coming above the diaphragm and conditions below the diaphragm. Then we can move on to the management. Management is also very important in case of pleural effusion. Can divide management under three headings, that is general management, chemotherapy, and management of fluid itself. In case of emergency or respiratory embarrassment is there, we will resort into emergency aspiration. So two type of aspiration is there: emergency aspiration and elective aspiration. So two type of aspiration is done in case of pleural effusion, that is emergency aspiration and elective aspiration. In emergency aspiration, there is no time. The specimen of fluid can be used for diagnosis also. The fluid is aspirated by thoracocentesis. The process is called thoracocentesis. And there is a particular area where the needle is inserted, that is in the 8th or 9th intercostal space in the posterior axillary line. 8th or 9th intercostal space in the posterior axillary line. It is done after giving anesthesia, and sufficient fluid is removed to relieve the distress. And the aspiration is done using a two-way syringe. That's very important. The two-way syringe is used in case of pleural fluid aspiration. When we discussed pneumothorax, there a three-way syringe is used for aspiration of air. Three-way syringe in pneumothorax. In case of pleural effusion, a two-way syringe is used. So that's emergency aspiration. Then what is elective aspiration? Here medical therapy is initiated depending upon clinical features. At first, the medical therapy, before aspiration, medical treatment is started or antibiotics may be started. And aspiration is done 3 to 4 days later after giving specific therapy. So aspiration is done after few days of giving treatment. That is elective aspiration. There will be some time, breathing time for doing aspiration. So two type of aspiration, emergency aspiration and elective aspiration. Then there are certain indications for aspiration. That is, they are large effusion up to clavicle. Then when there is cardiac or respiratory embarrassment, bilateral effusion, acute pulmonary edema, then secondary infection of effusion, persistence of fever and constitutional symptoms, then non-resolving effusion even after antituberculous treatment. Usually they will give antituberculous treatment, and if the effusion is not resolving, then it's an indication for aspiration. Then hemorrhagic effusion or with high content of protein. All these are indications for aspiration. Then there are complications of aspiration also there. And this include pleural shock due to vagal inhibition. Then if there is shock, urgent resuscitatory measures including injection of adrenaline and IV fluids are essential. It's an emergency, pleural shock. Then there can be bleeding into the pleural space also, Then entry of air into the pleura is another complication. Entry of air into the pleura during aspiration, giving rise to a condition called hydropneumothorax, that is presence of air and fluid in the pleural cavity. That is called hydropneumothorax. Then air embolism itself is another complication, air embolism. Then pulmonary edema. Pulmonary edema is a complication if the fluid is removed too quickly. And edema may develop in the re-expanded lung tissue. The lung may expand too quickly, leading to formation of pulmonary edema. So to prevent pulmonary edema formation, some air is allowed or sucked into the pleural space during aspiration. So these are the complications of aspiration. Then circulatory collapse also can happen as a complication. Then pneumothorax or empyema can also happen as a complication. Then in management, another the next phase is giving corticosteroids, then giving specific treatment to underlying disease, then advising exercises, respiratory exercises to encourage re-expansion of lung tissue after aspiration. All these come under management. So general management, chemotherapy, and management of fluid. These are the three headings coming under management. So that's about management of pleural effusion. You can refer go through the description for the PowerPoint presentation and the detailed medicinal management in the PowerPoint presentation. Thank you.